Hello, my name is Matthew Duprey. I'm currently a postdoctoral research associate at the Brown University School of Public Health. Today I'm presenting our poster on the complex interplay between pain, analgesics, and delirium in critically ill adults. I'm presenting this on behalf of our authorship team, which includes researchers at both Northeastern University and UMC Utrecht in the Netherlands. This research was supported by an American College of Clinical Pharmacy Foundation Futures grant. So we know that both pain and delirium are prevalent among critically ill adults. The interactions between pain and delirium are complex, multidirectional. Cohort studies, primarily those in older adults undergoing surgery, have found pain to be a risk factor for delirium. However, we also know that the analgesics that we give for pain management may also lead to an increase in delirium risk. So our objective was to explore the association between pain, delirium, and analgesics in critically ill adults. We conducted a secondary analysis of a prospective cohort. That cohort was consecutively admitted, critically ill adults, admitted for at least 24 hours to a 32-bed mixed ICU between January of 2011 and March of 2019. Daily mental status was classified as awake without delirium, delirium, or coma, and pain was assessed up to 6 times daily using a 0 to 10 centimeter visual analog scale when the RASS was at least -2, and with the critical care pain observation tool, or the CPOT, when RASS was less than or equal to -3. Maximal daily pain was categorized into mutually exclusive categories. Those were no clinically significant pain detected, a VAS of 0 to 4, or a CPOT of 0 to 2. Moderate pain detected, a VAS of 5 to 6, and a CPOT of 3 to 4. And severe pain detected, which was a VAS of 7 to 10, or a CPOT of 5 to 8. We then looked at the association between maximal pain on day T and mental status on day T plus 1, or the day after the pain was assessed, using multinomial logistic regression in a first-order Markov model. So our cohort was 4,075 patients, mean age of 61. 64% were male, with a median Charlson Comorbidity Index of 1 and an Apache 4 score of 58.5, which is roughly equivalent to an Apache 2 of 18. ICU characteristics, 35.1% of patients developed delirium at some point during their ICU stay. 85% of patients received an opioid, and that lasted for a median of 2 days while they were in the ICU. Those 4,075 patients contributed nearly 25,000 days to our cohort. Of those, nearly 15,000 were awake without delirium. 6,000 patients were assessed to have delirium, and a little over 5,000 patients had coma. Of those days patients were awake without delirium, 11.8% they reported moderate pain, 7.7% they reported severe pain, and no pain score was documented on 3.7% of those days. Of the 6,200 days with delirium, 11.9% there was moderate pain assessed, 7.1% of days there was severe pain, and 9.3% of days there was no pain score documented for those patients with delirium. And then in the 5,100 days with coma, there was moderate pain on 3.8, severe pain on 1.1% of days, and pain score was not documented in 47% of those days for patients who were comatose. When we ran those multinomial logistic regression models, we found that presence of severe pain, presence of moderate or severe pain, and peak pain score were potentially associated with a decrease in delirium. Odds ratios less than 1, not crossing 1 in the 95% confidence interval. When we then ran the model in a three-level variable using no pain as the reference category, we found that the association for moderate and severe pain was about 0.75 and did not cross 1. We then ran another model controlling for opioid dose where the odds ratio was unchanged. So we know there's some limitations. This was a single-center European cohort. However, it has similar case mix and opioid utilization patterns to ICU studies in Europe and the US. We know that missingness severely limits the interpretability of our results, and we know that VAS and CPOT evaluations are related to the level of consciousness, and self-report of pain is unreliable in patients with delirium. However, realizing the challenges of pain assessment in patients with delirium, pain seems not to be a strong risk factor for delirium in critically ill adults. Future research is necessary to better understand the complex relationship between pain and delirium in the ICU. And I would be happy to take any questions from anyone that has them. Thank you.